Hello everyone. I am supposed to be giving you a clinical overview of mitral stenosis and a brief clinical overview of mitral stenosis and mitral regurgitation. This is directed at the MBBS students. Please understand, I would like to emphasize that this is an aid and this will not substitute for the effort that you have to put in the ward by going and taking a proper history taking, developing your clinical skills and perfecting it. Now, we'll start with mitral stenosis. Mitral stenosis, as the word implies, it is a stenosis of the mitral valve. That means between the left atrium and it is obstructing the blood flow from the left atrium to the left ventricle. Now, the most common etiologies is whether it is an isolated mitral stenosis or it is associated with other valvular conditions. Usually, the most common etiology is rheumatic heart disease. Less common conditions include mitral angular calcification, congenital mitral stenosis, and rare conditions include amyloidosis and various other conditions. Now, let us start with the clinical features. Clinical features, symptoms. What are the most common symptoms of mitral stenosis? One, the patient can be asymptomatic and incidentally detected. Two, the patient can be symptoms. The most common symptoms are dyspnea. The dyspnea can start off with exertional dyspnea and progress on to become exertional dyspnea, dyspnea at rest, orthopnea, and PLD. The next common symptom that the patient can complain of is fatigue. Usually, this is when the patient has advanced mitral stenosis. Some of these patients can complain of hemoptysis. Patients can present with features of right heart failure. They can present with complications like atrial fibrillation, thereby they present with palpitations or sometimes thromboembolic phenomena. They can have complications of left heart. They can have present with left heart failure, recurrent bronchitis. These are some of the usual symptoms. Palpitations can be present if the patient develops atrial fibrillation. Now let's go to the signs. In the signs, we'll start first in the general examination. In the general examination, you can have a condition as something known as mitral phases. Now this is a rare thing. It's not commonly seen. It's usually seen only when the patient has advanced mitral stenosis. Now, what are the other signs that we can commonly find? Let's start with, in that order, we'll start with the pulse. The pulse is usually normal in a patient with mitral stenosis. Now, in some patients, especially when they have advanced mitral stenosis, you can have a low volume, a low volume pulse. If a patient develops atrial fibrillation, then you can develop irregular pulse. Coming to the cardiovascular system examination, inspection, palpation, percussion, auscultation. Let's start with the apex. The apex is usually a tapping apex beat that you can get. Two, in the apex itself, you can get a diastolic thrill can be present. Diastolic thrill can be present in some patients. Diastolic thrill can be present. You can have features of pulmonary hypertension, that is visible and palpable left second intercostal space pulsations. You can have a palpable P2. You can have a loud P2. Auscultation wise, you can have loud P2. In some patients, ejection systolic murmur, advanced stages Gram steel murmur, that is early diastolic murmur of pulmonary regurgitation. You can have features of right ventricular hypertrophy, that is visible and palpable epigastric pulsations. You can have parasternal heave. Now coming to the mitral area. In the mitral area, one, I said you're going to get a tapping apex beat. Two, you can have a diastolic thrill. Auscultation, what are the things that we can have? One, we can have a loud S1. Understood. Two, you can get an opening snap. Three, you can get a mid-diastolic murmur. So usually the mid-diastolic murmur attributed to mitral stenosis is a low-pitched, rough and rumbling murmur, best heard at the mitral area with the breath held in expiration, with the bell of the stethoscope, and the patient in the left lateral position. Now, the important thing about mitral stenosis murmur that you need to understand is it is a localized murmur. It is localized to the apex. It does not radiate. Mitral stenosis murmur. Along with this, you will have a pre-systolic accentuation. Understood? So altogether, a mid-diastolic murmur with pre-systolic accentuation, best heard in the mitral area with the breath held in expiration. It is a low-pitched murmur, rough and rumbling, with the patient in the left lateral position. If there is superimposed atrial fibrillation, what you're going to have is the pre-systolic accentuation will be lost. Now, what if the patient develops atrial fibrillation? What are the findings in a patient with mitral stenosis if he or she develops atrial fibrillation? One, you're going to get an irregular pulse. Okay, you're going to have absence of A waves will be absent in JVP. Your S1 will be of variable intensity. The pre-systolic accentuation of the mid-diastolic murmur will be absent. Understood? So you're going to have an irregular pulse. A waves will be absent in the JVP. S1 will be of variable intensity. Pre-systolic accentuation will be absent. I've told the signs of pulmonary hypertension, the signs of right ventricular hypertrophy. Now, along with this, every time, whenever we have a cardiovascular system case, in the general examination, after you talk about the vital signs, when you talk about the head to foot examination, any cardiac system, you should be talking about 2-3 things. One is signs of right heart failure or congestive cardiac failure, which include one, a raised JVP. You'll have tender hepatomegaly. You can have ascites and pedal edema. Fine. So you're going to have signs of right heart failure, raised JVP, tender hepatomegaly, ascites, pedal edema. The first to appear will be the JVP, and the last to disappear also will be the JVP. Next, in any patient when cardiovascular case, so one, you should be always talking whether the signs of right heart failure are present. Two, you should be talking about features of infective endocarditis. What we look for is fever, pallor, clubbing. In the fundus, you look for rogue spots. In the hand, you look for Osler's nodes in the pulp of the femurs, Janeway lesions. Janeway lesions. You look for splenomegaly. In the nails, one more thing that you can look for is splinter hemorrhages. You look for splenomegaly and absence of peripheral pulses. So, fever, pallor, clubbing, road spots, splinter hemorrhages, Janeway lesions, Osler's nodes. You look for splenomegaly and absence of peripheral. So every cardiovascular case, you should mention this in the general examination, especially in the head to foot area, signs of right heart failure, signs of infective endocarditis should be. And specifically, if you're dealing with aortic regurgitation lesion, you write about peripheral signs of, you talk about peripheral signs of AR. Okay, clear? So we have talked about the right heart failure. We have talked about the signs of infective endocarditis. We have finished off the etiology of mitral stenosis, the symptoms, the signs. Now let's go to the investigations. What are the common investigations in a patient with mitral stenosis that we are supposed to do? One is ECG. Your ECG can be normal. It can show features of atrial fibrillation. That is two things that you look for: absence of P waves absence of P waves, and varying RR interval. So absence of P waves and varying RR interval. ECG can be normal. Features of AF can be present. Features of right ventricular hypertrophy can be present. Tall R waves. Understood. Then X-ray. What are the findings of mitral stenosis that we look for in the X-ray? In the X-ray, one, specifically mitral stenosis, you can have a double heart border. Two, you look for straightening of the left heart border. This occurs, straightening of the left heart border occurs due to pulmonary artery hypertension. You can have widening of carina. Understood? Then this is specifically double heart border, straightening of the left heart margin, widening of the canal. Sometimes you can have mitral calcification. Mitral valve calcification can be seen. Then, like any patient, when the patient goes into heart failure, you look for features of heart failure like curly A lines, curly B lines. You look for bad wing appearance. You look for pulmonary pleural effusion. These are some of the things that you can see in X-ray. Finally, specific investigation for this is echo. In the echo, what are the things that we look for is, one is confirming our finding of mitral stenosis. We look at the valve orifice. Is it mild, moderate, or severe mitral stenosis? You see if the mitral valve is calcified, because this is going to make a difference in the management. Understood? Any features of infective endocarditis in the form of vegetations, features of pulmonary artery hypertension and right ventricular involvement. Understood? Left atrial enlargement. If the patient has atrial fibrillation, you look for left atrial thrombus. Understood? Vegetations infective, left atrial thrombus, pulmonary artery hypertension. See, so mitral stenosis, you look and you confirm whether other valves are involved. Clear? So I believe I've given you a brief overview of mitral stenosis, the common etiology, that is rheumatic heart disease, the symptoms, that is dyspnea, which is progressively worsening, exertional dyspnea worsening, palpitations, hemoptysis, features of AF, features of atrial embolism, thromboembolism, in the bronchitis, hemoptysis, signs, starting with the mitral fascia is only seen in severe mitral stenosis. Your normal pulse or low volume pulse in severe mitral stenosis, atrial fibrillation features, very irregular pulse with an apex pulse deficit more than 10. Then going to the, in the general examination, we look for signs of right heart failure, signs of infective endocarditis. Then coming to the apex, the signs of right ventricular hypertrophy, signs of pulmonary artery hypertension, and we are looking for signs of, and the mitral stenosis murmur. That is a mid-diastolic, loudest one, opening snap, mid-diastolic murmur with pre-systolic accentuation. Now, two features of severity of MSS, the A2OS gap. So, if the one is the A2OS gap and the length of the murmur. Understood? So the length of the murmur keeps increasing and the A2OS gap keeps shortening in a patient with severe MS. Now, next, what is the treatment options that is available? So any patient, one, we will treatment of heart failure, that is salt restriction, fluid restriction, diuretics, and all, treat the precipitating factors of heart failure. Two, infective endocarditis treatment and prophylaxis. Three, you go for rheumatic fever prophylaxis, and 4, whether surgical management in those who have indications for that. Okay, now we will talk about mitral regurgitation. So mitral regurgitation, again the valve involved is the mitral valve. It is not closing properly. So there is regurgitation of the blood from the left ventricle into the left atrium. Let's start with the etiology. Now etiology wise, you can divide it into acute, various ways you can divide it, acute and chronic causes. So acute causes, one is trauma. Blunt trauma to the chest can produce mitral regurgitation. Infective endocarditis can produce. Rheumatic fever. Please be clear, it is rheumatic fever and not rheumatic heart disease. So rheumatic fever can produce myocardial, acute myocardial infarction, papillary muscle dysfunction, and the patient can develop any iatrogenic procedures. Also, some of these procedures rarely can produce acute MR. Chronic, most common is rheumatic heart disease. Mitral valve prolapse can progress on to develop mitral regurgitation. Ischemic heart disease, cardiomyopathy, infective endocarditis, connective tissue disorders like rheumatoid arthritis and various connective tissue disorders also can produce chronic mitral regurgitation. Some literature may give you also dividing it into cardiac causes and non-cardiac causes. When you talk about cardiac causes, you're talking about ischemic heart disease, cardiomyopathies, mitral valve prolapse, non-cardiac like trauma, infective endocarditis, or connective tissue disorders all will. Now let's go to the symptoms. What are the symptoms that a patient with mitral regurgitation can have? Remember, mitral regurgitation is a volume overload condition. So the symptoms are again dyspnea, which will progressively worsen to starting out with exertional dyspnea, dyspnea at rest, orthopnea, and PND. 2, you can have palpitations. Now there is 2 ways in which your patient can have, and 2 types of palpitations that mitral regurgitation patient can have. One, per se due to mitral regurgitation. That is, you can have exertional fast regular palpitation. On exertion, patient develops fast regular palpitation. 2, you can develop the palpitation due to arrhythmias. That is, paroxysmal irregular spontaneous onset of, for example, atrial fibrillation, spontaneous irregular palpitations. So palpitation due to the volume overload condition and palpitation due to the arrhythmias. Understood? Then patient can have fatigue, patient can have features of heart failure, right heart failure, left heart failure. These are some of the symptoms that a patient with mitral regurgitation can come to. Let's go to the signs. Starting with the general examination. So let's start with the pulse. What are the pulse abnormalities that you can have in a patient with mitral regurgitation? One, the pulse is going to be, because it's a volume overload condition, you're going to have a high volume pulse. Understood? 2, there can be a collapsing character to the pulse. If the patient develops atrial fibrillation, you're going to have irregular pulse, like I mentioned in MS, same here, and apex pulse deficit more than 10. Okay, so pulse we finished. Then we go into, like I said, like I mentioned in the previous one, we should definitely look for signs of right heart failure. That includes raised JVP, tender hepatomegaly, ascites, pedal edema. First to appear JVP, last to disappear JVP. Then signs of infective endocarditis, which I mentioned earlier, that is fever, pallor, clubbing. You can have rod spots in the eye. You can have Osler's nodes, Janeway lesions, splinter hemorrhages, splenomegaly, absence of peripheral pulses, signs of heart failure, signs of infection. Yes, this will be there as part of the. Okay. Now coming to specifically cardiovascular examination. Starting off, let's start with the apex. You're going to have an apex that is hyperdynamic apex. So it's going to be the apex is going to be hyperdynamic apex. It is going to be because it is left ventricular shifted down and out. So rather than in the one in the fifth intercostal, it's going to be sixth or seventh and lateral. So shifted down and up. Hyperdynamic apex. You can have, it can be systolic thrill can be present in the mitral area. So the apex I've told you, hyperdynamic apex shifted down and up, systolic thrill. Now you can have in the inspection you can find a rocking precordium. Understood? Because like I said mentioned earlier, mitral regurgitation is a volume overload condition. So when you are having a volume overload condition, you're going to have sometimes a rocking precordium. These are the classical findings. Every patient need not have all of these findings. Then, when you have a patient with the, you're going to have, like I mentioned in MS and MR, in mitral stenosis, you look for signs of pulmonary artery hypertension. What are the signs of pulmonary artery hypertension, which I mentioned earlier? Again, I mentioned in one form. One is visible and palpable left second intercostal space pulsations, a palpable P2, loud P2, ejection systolic murmur in the left second intercostal space. Advanced stages, you can have early diastolic murmur, grand steel murmur directly to pulmonary regurgitation. What are the signs of right ventricular hypertrophy you should be looking for? Any valvular condition. One is visible and palpable pulsations in the epigastrium and parasternal heave. Now, let us specifically go to the mitral regurgitation findings that we can get. So, what are the things in auscultation? One, you can get a soft S1. In mitral stenosis, it was loud. Here you get a soft S1. You get a pan-systolic murmur. Understood? A pan-systolic murmur, a soft, the classical description is a high-pitched, soft, blowing pan-systolic murmur, best heard in the mitral area, with the breath held in expiration, with the patient in the breath held in expiration and patient in the left lateral position. Now, best heard with the, because it's a high pitch murmur, best heard with the diaphragm of the stethoscope. Now, if the predominantly anterior mitral leaflet is involved, the murmur will radiate to the base of the heart. The base means when we are talking about is the anterior part of the chest. If it is predominantly posterior mitral leaflet that is involved, it will radiate to the posterior part, to the axilla and the back. This will give you a clue whether which is predominantly involved. So you're supposed to look for, unlike in a mitral stenosis murmur which is localized, this will radiate. So that we have now inspection, palpation, percussion, auscultation, the general examination findings, everything we have covered of it. Now, one more finding that you may find in patients with mitral regurgitation, which you should be aware of, is like I mentioned earlier, mitral regurgitation is regurgitation of the left ventricular blood into the left atrium. So when this blood flows back into the left ventricle across the mitral valve, you will hear a murmur mimicking like it's a flow murmur. Understood? It is a flow murmur. It will mimic like your mitral stenosis. What I mean is you will get a mid diastolic murmur. How do you differentiate? Is this patient having mitral stenosis? One, you're not going to have loudest one. You're not going to have opening snap. You're not going to have pre-systolic accentuation. In other words, other features of mitral stenosis will not be present except that the mid diastolic murmur secondary to the flow. Understood? Okay, so we have talked about the etiology, we have talked about the symptoms, we have talked about the signs. Now let's go to the specific investigations. We'll start with the ECG. What are the ECG findings that you can get in a patient with mitral regurgitation? One, it can be normal. Two, the patient can have features of atrial fibrillation, like I mentioned earlier. You can have varying RR interval. Two, absence of, or the first important thing is the absence of P waves. So absence of P waves. Okay. Now, what else can you have? Left ventricular overload features can be there. Okay. Features of left atrial enlargement, that is a P mitral. This can be seen also in mitral stenosis. P mitral can be present. Next, what we look for is the next investigation that we do is X-ray. So when you do an X-ray, you are not going to have specific findings. Unlike in MS, you're not going to have specific findings of mitral area. You're going to have in the X-ray one, cardiomegaly. Two, you may find mitral valve calcification. Okay. Signs of heart failure can be present, which I mentioned in mitral stenosis. I'm not repeating it the whole thing again. Understood? These are things that you can find in X-ray. Now, let's go to the next investigation, that is echo. So, why do we do an echo? One, we want to confirm our findings. So, confirm the presence of mitral valve involvement, mitral regurgitation. You can assess the severity of the mitral regurgitation. You can see if the valves are calcified or not, which is important in our management. If there are features of infective endocarditis, excuse me, left atrial enlargement, presence of thrombus, features of pulmonary artery hypertension and right ventricular hypertrophy, right ventricular involvement, whether other valves are involved. It also gives you a clue regarding the etiology, like I mentioned earlier. If there is a papillary muscle dysfunction secondary to ischemic heart disease, you can identify that. If it is due to infective endocarditis, you can identify that. If the patient has amyloidosis or any deposition or connective tissue disorder related, so pericardial effusion, any other diseases, you can identify that. These are some of the use of echo in a patient with mitral regurgitation. Excuse me. Now coming to treatment. The simplistic way of treatment is one, treat the heart failure. So that is salt restriction, fluid restriction, diuretics, and treat the precipitating factors. Two, infective endocarditis prophylaxis. Treat wherever possible the underlying cause. And four, where required, if the conditions are met, surgical management, including mitral valve replacement. Okay, so I've given you a brief overview of mitral stenosis from a clinical overview of mitral stenosis and mitral regurgitation. What are the things we should be specifically looking for? The most common findings, the most common symptoms. Thank you very much.